Today we'll discuss about particularly the clinical current updates and impacts on the clinical practice with dapagliflozin. So, yeah. So we'll discuss the topic on the heading of SGLT2 inhibitors, changing landscape for treatment of diabetes. What are the dapagliflozin's metabolic effect, and what are the studies, cardiorenal outcome trials like DECLARE-TIMI 58, DAPA-HF study and DAPA-CKD study, and what is the difference between DAPA versus remogliflozin, what are the approved indications, and what are the take-home messages from the particular topic. So SGLT2 inhibitors are the changing landscape for particular treatment of diabetes. People see the SGLT2 inhibitors are relatively new class of particularly anti-hyperglycemic agents for management of type 2 diabetes. And we know everybody the mechanism of action, it reduces the reabsorption of glucose in kidneys. It facilitates its excretion in urine by inhibiting particularly this high capacity SGLT2 located in the proximal convoluted tubule, and thereby lowering the glucose level independent of insulin action. Recent trials have demonstrated there is a significant cardiovascular and renal benefits of SGLT2 that resulted in a paradigm shift in management of diabetes. And we everybody know in 2019 and 20 we'll see all sort of guidelines. Again, even if before metformin, after lifestyle, even if before metformin, if all sort of ASCVD risk factors are there, if someone is having microalbuminuria CKD, SGLT2 has been placed. Even if before metformin, one can directly go to SGLT2 even if starting prior to metformin. Coming to the dapagliflozin, among this SGLT2 dapagliflozin is weak India, mainly three important gliflozins are available. One is empagliflozin, dapagliflozin and canagliflozin, and of course one Indianized gliflozin, remogliflozin is there. And DAPA is a SGLT2 inhibitor that is approved for treatment of type 2 diabetes in almost all countries or European countries, US, India, everywhere it is available. It is a highly potent and a reversible SGLT2 inhibitors, having more than 1400 times more selectivity toward SGLT2 than SGLT1. It is the main transporter which is responsible for glucose absorption in the gut. And dapagliflozin induced this glucosis in patients of type 2 diabetes is associated with a significant calorie loss. We know the patient on any sort of gliflozin, there is a weight loss of 3 to 4 kg. And this moderate reduction of body weight, majority time this weight loss is due to loss of fat, not the lean body mass. And this mild osmotic diuresis can lead to also a transient natriuresis initially, but on continuous use, there is no natriuresis, or usually the body becomes a balancing state, which leads to actually no further sodium loss. And there occurs a moderate decrease in the blood pressure. We know initially there is some sort of decrease in circulatory volume because of these diuretic or natriuretic properties of the drug, but in the latter phase itself has actually there is reduced in particularly this sympathetic tone is reduced. Also, there is some sort of vasodilatory effect in the periphery that leads to actually minimal reduction in the blood pressure among those group of patients. If we see the glycemic control, then there are numerous randomized double-blind multicentric phase 3 trials with DAPA as a monotherapy or in combination therapy has been there. And we have some real-world evidence data like CBD Real 1, 2, 3. They have given clear-cut in lakhs of people. They have given a significant judgment that dapagliflozin is one of the drug which has a significant better control, not only for the glycemic control point of view, also whatever that RCTs has given for particularly cardiovascular point of view, renal point of view, same thing it also has been replicated in the real world evidence status. So the reducing body weight and blood pressure in a broad spectrum of patient of type 2 diabetes, that including those with high baseline HbA1c, even if more than 9, and even if elderly people, those who are more than 65, this drug can be safely used. But you have to be a little bit cautious when you are using in elderly population. And this is the cardiorenal protection mechanism overview. You will see SGLT2 inhibitors, they at one side, they cause natriuresis and also glycosuria. And this glycosuria leads to actually weight loss along with good glycemic control. And this natriuresis has three important factors. It causes some sort of lowering of the blood pressure. This glomerular tubular feedback is inhibited, and also there occurs amelioration or decrease in the volume overload. And this tubuloglomerular feedback is one of the important factor which causes intraglomerular pressure reduction. And all those things these things has good effect, particularly from the renal point of view, also good effect from the cardiovascular point of view. Again, there are certain additional factors or mechanism through which it causes some sort of renal protection, which is it reduces oxidative stress, reduces fibrosis induction, it reduces local inflammation, reduces tubular senescence, also reduces glomerular damage. All those things again give some sort of possible mechanism or plausible mechanism for protection of the kidney point of view. And there are certain landmark trials, outcome trials. You will see the first one is particularly DECLARE-TIMI 58, and the trial design is taken almost 17,160 type 2 diabetic patients, and there are two groups: those who have been established CV disease, taken close to 974 patients, and those who are having multiple risk factors, there are additional 10,180 patients were taken in that, and there is a randomized 1:2 and double-blind, and then one group DAPA is there and another group is placebo is there, and that it is an event-driven study. At least more than 1,390 events should be done or should be there to end the study or to make the study powerful or to make the study powerful. And there is a median age follow-up up to 4.2 years. And the safety is the mesh they try to from the mesh like cardiovascular disease, microinfarction, ischemic stroke. Also for dual efficacy, CVDA, hospitalization due to heart failure, and 3-point mesh, they try to see that. And if you see the baseline characteristics, it is almost mean age is 64 and almost 37% are female, and almost all continents, North America, Europe, Latin America, Asian Pacific, everywhere patient has been taken. 40% people have established CVD, and baseline H1 is 8.3%. And the baseline EGFR in particularly this DECLARE-TIMI is 85. That means majority of people have normal GFR. And patients were on other drugs, any sort of people think metformin, insulin, sulfonylurea, DP4, GLP-1, shift agonists, everything. There again, other drugs like ancillary drugs like antiplatelet drugs, ARBs, beta blockers, ACE inhibitors, they are also, some of the people are with this along with statins. And what they found in the Dapagliflozin group, if you will see the CVD and hospitalization due to heart failure together, then the hazard ratio is 0.83. That means there is a 17% reduction with DAPA group in comparison to placebo. And again, the superiority testing P value is 0.005. Again, it shows it is superior for particularly CVD and heart failure combined together. If you will see the 3-point mesh, the hazard ratio is 0.97. That is only 7% reduction. And P for non-inferiority is statistically significant, but P for superiority is not significant. So there is 3-point mesh reduction is there, but it is not found to be superior. But non-inferiority has significantly. If you see the secondary endpoints like first renal composite endpoint, a 40% reduction in GFR or ESRD or renal or CVD was found in the DAPA group in comparison to the placebo with a statistical significant P value with a hazard ratio of 0.76. That means a significant improvement is there. And if you see the all-cause mortality, again, the hazard ratio is 0.93 with a P value of 0.02. That means it is actually, for the superiority point of view, it is not found to be superior. So if you are summarizing the DECLARE-TIMI, if someone is having a prior history of microinfarction, then the DAPA gives benefit of 3-point base, CVD, hospitalization due to heart failure, renal failure, everything is there. If someone has just a prior MI, then again, mesh 3-point base, CVD and heart failure, renal, every benefit is there. But if someone is having particularly ACVD, no prior MI, or for primary prevention purpose, you are not getting the benefit of mesh. But of course, from the cardiovascular disease or hospitalization due to heart failure, and renal benefit is still there for ACVD risk factors alone without any events, also for the primary prevention point of view. Let's discuss about the DAPA heart failure. The beauty of DAPA heart failure is that almost a good number of people are there having non-diabetic. So when Dapagliflozin was first initially started, it was started as an anti-diabetic drug, but this is the study which is showing that majority, a lot of the people having non-diabetic are also included in this study. And usually inclusion criteria is NIOH class 2 to 4, ejection fraction less than 40%, or pro-BNP more than 600 picogram per ml. And exclusion criteria is GFR less than 35, and if systolic blood pressure is significant low, like less than 95, or patient is type 1 diabetes. And here they want you to make the study powerful, at least 844 events should be there, and the composite endpoint is CV death, hospitalization due to heart failure, or urgent heart failure visit. And there are a lot of visits, and also 1:1 randomization were there in the study. And you see that almost the mean age in both diabetic and non-diabetic group is almost same, and both diabetic and non-diabetic group is almost matched in majority of the things. Blood pressure, ischemic etiology, whatever maybe you discuss, almost majority part it is almost matched. So here diabetic is 2100 people are diabetic, whereas non-diabetic is 2600 people. And patients were all other treatments like diuretics, ACE inhibitor, or ARB or ARNI, then beta blockers, then additional like ICD, CRT, also some of the people are there. So they were all were included in the study population. So what they found, those who are diabetic, the hazard ratio for CV death, hospitalization due to heart failure, or urgent heart failure visit, if you take together, then hazard ratio 0.75. In diabetic, there is 25% reduction is there with dapagliflozin. Whereas those who are non-diabetic, the hazard ratio again is further low, that means 0.73. That is a 27% reduction in non-diabetic population altogether combined. But if you take only CV death and hospitalization due to heart failure, then again same thing was replicated among the diabetic. The hazard ratio is 0.75, and non-diabetic is 0.73. Similar thing is actually there. And if we see the all-cause death in the diabetic, then actually the hazard ratio is 0.78, and in the non-diabetic it is hazard ratio 0.88. That means again in the diabetic all-cause death, in the diabetes there is 22% reduction, and in non-diabetic population there is 12% reduction with dapagliflozin in comparison to the placebo group. So what they concluded, among the patients with heart failure, a reduction in ejection fraction, those who receive dapagliflozin has a lower risk of worsening heart failure or death from cardiovascular causes and better symptom scores than those who are receiving placebo. And this benefit was regardless of presence or absence of diabetes. That is the beauty, that after this study, dapagliflozin was actually approved for use in heart failure patients, even if in the non-diabetic patients. So based on this DAPA heart failure, US FDA has approved DAPA to reduce the risk of CV death or heart failure hospitalization in patients with heart failure with reduced ejection fraction with and without type 2 diabetic patients. So let's see the DAPA-CKD patient. CKD is the one of the kidney trial. Here actually almost 386 centers in 21 countries, 4,304 patients were randomized in a double-blind placebo-controlled trial. At one group, it is actually DAPA received DAPA 10 milligram, and matching placebo and still was given in the opposite group. And inclusion criteria is those more than 18 years of age, GFR between 25 to 75, urine albumin creatinine ratio between 200 to 5,000, and patient is already on a stable tolerated maximal dose of ACE inhibitor or ARB for more than 4 weeks. And exclusion criteria is type 1 diabetes, those having polycystic kidney, lupus nephritis, or ANCA-associated vasculitis, and also patient is on immunosuppressive therapy. They were excluded from the study. What they found, if you see the primary outcome, there is a more than 50% GFR sustained, more than 50% eGFR reduction or ESKD or renal or CV death. In the placebo group, there are 312 events, and DAPA group it is 197 events. So NNT is 19, and p-value is very much strongly significant with hazard ratio of 0.61. That is almost a 39% reduction in the DAPA group in comparison to the placebo group. And if you see the summary of primary outcome, if you see the more than 50% eGFR decline in the DAPA group, it is very much significant. Again, among the ESKD group, eGFR less than 15 ml, it is significant, but less than particularly more than 50% GFR. Those who are on chronic dialysis, again they are getting benefit. But from the renal death and also transplant point of view, actually it is not studied. And for the CV death point of view, again, it is giving significant benefit, having those already on CKD. And if you see the secondary outcome, that is sustained more than 50% eGFR decline or ESKD or renal death. In particularly the DAPA group, it is 200, placebo group, it is 243 events, whereas in DAPA group with 142 events with hazard ratio of 0.56. That means almost a 44% reduction in DAPA number of events in the DAPA group in comparison to the placebo group. So a significant improvement in particular renal outcome in comparison to the placebo group. So in patients with CKD, with and without type 2 diabetes, this use of dapagliflozin compared to placebo significantly. That is reducing the risk of renal failure, reduces the risk of CV death and heart failure hospitalization. Also, it prolongs the survival of the patients. Now let us compare our own Indianized gliflozin, remogliflozin, which is available in India, probably in India only, and of course South Korea and also Japan are probably some of the places where it is available. But DAPA is not like that. If you see the global presence, it is almost dapagliflozin is present everywhere in the world, whereas Remo is available only in India and probably in South Korea. Approved indication, it is glycemic control. Now it is heart failure with reduced ejection fraction. Again, with DAPA-CKD, we can get also those who are having diabetic or non-diabetic, having proteinuria, or to reduce the particularly renal events, you can use dapagliflozin. But where Remo is only for the glycemic control. And if you see what are the heart failure and DAPA-CKD are the major landmark trials with us, but with Remo, there is nothing is there. If you see the strength of evidence, there is 1419 results in PubMed, whereas in remogliflozin there is only 29 results. And if you see the dosage frequency, it is once daily, whereas for the remogliflozin, again, you have to go for twice daily dosing. So DAPA has been approved indications by DCIJ in adults aged more than 18 years or older for type 2 diabetic mellitus to improve the glycemic control. And again, adults for treatment of heart failure with reduced ejection fraction. These are the indications by DCIJ. DCIJ has been actually approved in India for its use. So, finishing my talk with this take-home message: dapagliflozin lowers the glucose level independent of insulin action. It provides effective glycemic control and also reduces the blood weight and blood pressure. It reduces the risk of worsening of heart failure and death from the CV causes. It reduces the progression of renal disease, lower risk of hypoglycemia. It is highly cost effective. Hence, it should be a part of the therapeutic regimen for all eligible type 2 diabetic patients. Thank you.